lecture, and we go skip now to Dr. Jabir Abdullah Kutty, and he will give us some lecture according in-stent restenosis types and management in some cases. Welcome.
Thank you, Dr. Farhan. Can I share my screen?
Yeah, please. We can see now your slides, and you can go ahead.
So in-stent restenosis with the second and the third generation DES is still a major therapeutic challenge despite the advances that we could gain in the stent design, the drug, as well as the polymer. The previous classification, the first classification introduced for in-stent restenosis was the Meheran's classification, which is no longer relevant in the drug-eluting stent era. It was for the bare metal stent era. So this is the 2021 classification. Article published in June 2021, the Waxman in-stent restenosis classification, which is based basically on the mechanism of restenosis. The type 1 A is stent under expansion is a mechanism that is a mechanical problem producing in-stent restenosis, and the type 1B is the stent fracture. Type 2 is the biological mechanism producing restenosis. Type 2A is neointimal hyperplasia. Type 2B is neoatherosclerosis non-calcified. Type 2C is neoatherosclerosis calcified. And 3 is a mixed pattern of biological and mechanical problem. And 4 is chronic total occlusion. And 5 is restenosis occurring in DES more than 2 layers of stent. So this is stent under expansion type 1A, neointimal hyperplasia type 2A, non-calcified neoatherosclerosis type 2B, calcified one type 2C, mixed pattern type 3, and multiple stent layers, which is type 5. I'll show a few cases. The case 164 years old male, he had undergone a PCI to LAD from, in fact, left main to LAD. This was done elsewhere. At that time, they put 2 stents, one from LM to LAD and another overlapping stent to the distal part. Under-expanded by more than 50% at that time. They couldn't do much thing. Their balloons were not expanding, so they left it like that. Patient was doing well till 4 months ago when he started developing effort angina. So we saw this angiography, then we thought our plan should be wire it, balloon it, do an imaging, find out what is happening, then if required, IVL or a high pressure balloon dilatation. We dilated with a small sized balloon, tried to pass in an OCT catheter, it was not crossing. So we went ahead with aggressive dilatation, and we went ahead with the OPN balloon at high pressure. It could completely open the unexpanded lesion. And as you can see in the OCT, the lesion is reasonably expanded with some calcium around. So this is a typical type 1A, that is the mechanical problem. It was basically under expansion of the stent, and we opened it up with the OCT showing this thing. And then now we thought after seeing the OCT, there is no need of any further DES there. So we went ahead with a 3.5 millimeter drug-eluting balloon. And this is the final angiographic result with the OCT showing. You can see the OCT showing a decent expansion of the stent where it was previously under-expanded. And there were few struts which were overcrowded across the circumflex ostium. And after the final high pressure balloon dilatation and the depth, you can see the stents were moved out of the circumflex ostium also. So it seems to be a decent result, but it is restenosis. We do not know whether the patient will come back. Patient who had undergone a CABG 5 years ago, at that time the RCA was not deceased, so they grafted the LAD and the OM, LM, or LAD OM and the diagonal. 5 months ago, he had an inferior volume, underwent angioplasty, primary angioplasty with 2 DES, 38 millimeter, 2.5 DES with overlap. Now he presented with class 3 angina, and you can see there is a significant restenosis at the overlap area. We wired, balloon, did an OCT, and the OCT is showing under expansion of the stent, neointimal proliferation, and under expansion is due to nothing else, but it is a undersized stent. I think it's almost a 3 to 3.5 millimeter vessel, and in the proximal part, it's likely to be 4 millimeter vessel, where a 2.5 millimeter stent was used. So you can see there is neointimal proliferation, significant neointimal proliferation, under expansion of the stent, and in fact, at the proximal part, there is a malposition of the stent. So it is a mixed pattern. That is the type 3. There is mechanical problem, there is a biological problem. So we went ahead with the aggressive dilatations with balloon, and then a higher sized disc, 3 millimeter disc in the distal part with overlap of a 3.5 millimeter disc, and the proximal area was post-dilated. It was post-dilated with 3.5 mm balloon, and the proximal area with a 4 mm NC balloon. And this is a result. And the OCT showing some amount of malposition in the proximal part, which was corrected again with a further high pressure dilatation with a 4 mm balloon. So aggressive bed preparation followed by proper sizing of stent with another drug and high pressure post dilatation. That was the thing. So case 3 is a 54 years old male. He presented with restenosis of the RCA. At that time, it was a focal restenosis. You can see this is the type 2B, type 2A, that is new, that is neointimal proliferation. So we went ahead with the balloon dilatation, another layer of stent, another drug-eluting stent. So you can see the neointimal proliferation. It was a well-expanded stent. And the final OCT result at that time, it's a well-expanded stent without malposition and without under-expansion. Now we have 2 layers of stent at the mid part. What happened after 4 months? He again came back. Now there is a restenosis of the RCA stent, and there is aggressive neointimal proliferation with 2 layers of stent. So this is type 5. So now what to do? So we went ahead with a cut scoring balloon followed by a high pressure balloon dilatation using a Pantera Leo. And this aggressive dilatation resulted in a, can see the OCT resulted in a edge dissection at the distal part of the stent. And that edge dissection we covered with another stent, and the overlapping stent area where there was restenosis, it was tackled with a drug-eluting balloon. And this is the final result in the OCT, which shows a decent result. So this is a re-restenosis with that treated with a depth. And these are also, there is another 5 to 10% chance of recurrent restenosis in this patient. This angioplasty done in 2010 to LAD. Now the patient came back with a effort angina. The OCT shows neoatherosclerosis. This is a type 2C, that is neoatherosclerosis with calcification. You can see the neoatherosclerosis, fibroathyroma, microchannels, and calcium. So it is neoatherosclerosis. We went ahead with aggressive balloon dilatations, but the lesion was not giving way despite the use of a cutting balloon. We did another round of OCT after some balloon dilatations. There is some amount of expansion of the lesion, but not the correct, at the correct point of the lesion, there was no expansion. So there is some amount of calcium also. We thought we'll go ahead with a rotablation. So we went ahead with the rotablation. It's a 1.5 millimeter per 150,000 rotations. And even after the rota, the balloons were not giving, there is a dog boning effect of the balloons. The balloons are not expanding. So we thought of what is the option? Is it an IVL or an OPN? So we opted for the OPN. The OPN, you can see the third frame, the OPN expanded, it ruptured at 40 atmosphere, but at that time it could open the lesion. Then we again dilated, and this OCT now shows the lesion, the tightest lesion, which was non-yielding, now could yield, and it was dilated and ready for a stent implantation. So now the bed is ready for the stent implantation. We put another drug-eluting stent, 3 millimeter, and post-dilated with 3 millimeter non-compliant balloon with a good result. So this is the last case, 57 years old male. He underwent a LMDK crush with multi-vessel PCA 4 months ago. Now with accelerated angina, you can see the malignant restenosis. LM ostium, there is 90% restenosis. LAD, there is restenosis. The circumflex is totally occluded, and the RCA is having a 90% ostial restenosis. So imaging, we didn't do the imaging, risky. And here, there is no other evidence is required. Coronary angiography is sufficient to decide the next line of management that we thought is CABG. And there are two more modalities of therapy. One is the intracoronary brachytherapy. Another is the excimer laser coronary angioplasty. Both are useful, especially in recurrent restenosis with multiple layers of stents. I don't have personal experience with both these therapies. So the current 2021 treatment of ISR types and treatment: type 1 mechanical under expansion, go for a high pressure balloon, if needed rotablation, IVL or excimer laser. Stent fracture, balloon angioplasty followed by DES. Type 2 biological neointimal hyperplasia, balloon angioplasty, scoring balloon followed by DES or vascular brachytherapy. Neoatherosclerosis, it is just like the de novo atherosclerotic lesion. Dilatation followed by drug-coated balloon or drug-eluting stent, and vascular brachytherapy is another option. With calcification, we may have to go for calcium modification with IVL, rota, or excimer laser. And then the use of a drug-coated drug-eluting stent or vascular brachytherapy. The mixed one, it is a mixed mechanical and biological, so the treatment is individualized. For CTO, a drug-coated balloon, drug-eluting stent, or vascular brachytherapy. If the PCI is unsuccessful, coronary artery bypass grafting or optimal medical management is the option. When you have more than 2 layers of DES with an instant restenosis, that is the type 5 PCI, high pressure balloon followed by drug-coated balloon or vascular brachytherapy. Another option is CABG if just like the last case, there is extensive and malignant restenosis. Thank you so much for your patient listening.
Thank you for great cases and algorithm to show us how to manage in-stent restenosis. There are many options, and imaging again very crucial.